My name is Dr. Nitin Golop and I am the first author on this study. South Asians are the largest ethnic minority group in the UK, comprising of about 5% of total UK population. UK census data show that South Asians suffer from high coronary mortality compared to the indigenous white population. It has been debated whether this high mortality in South Asians is due to high incidence of the coronary heart disease or due to the high case fatality following manifest disease such as acute myocardial infarction. Therefore, we conducted this study in UK comparing survival in South Asian and white European patients admitted with acute myocardial infarction. The study was a retrospective analysis of routine care data on 4,111 patients hospitalized with acute myocardial infarction at the University Hospital of Leicester between October 2002 and September 2008. The data were taken from the National Myocardial Infarction Audit Program database, that is the MyNAP database. We measure their survival from the date of admission until the date of death or end of follow-up, censored at 30th of September 2009. The primary endpoint was all-cause mortality. We determined the association between South Asian ethnicity and mortality following acute myocardial infarction using the Cox regression analysis. We pre-selected the variables known to have association with both ethnicity and mortality following myocardial infarction as the confounders in the Cox model. Thus, we included age, gender, type of acute myocardial infarction, prior history of diabetes, hypertension, coronary heart disease, and smoking status as the confounders in the models. For a robust analysis, we further adjusted for several other variables known to influence prognosis following myocardial infarction. Compared to white European patients, South Asians were on average 5 years younger and had higher prevalence of cardiovascular risk factors including diabetes. During the median follow-up of about 3 years, just over 22% South Asian patients died compared to 26% white Europeans. On univariate analysis, South Asian ethnicity did not show any association with mortality. This observation did not change on multivariate analysis, adjusted initially in Model 1 for age, gender, type of myocardial infarction, prior history of diabetes, hypertension, coronary heart disease, and smoking status, and adjusted further for several additional variables. These findings were similar for mortality at various time points in the landmark analysis and for mortality in subgroup of patients with ST elevation and non-ST elevation myocardial infarction. So just to summarize, we found that survival up to 3 years following acute myocardial infarction was similar for South Asian and white European patients in the UK, even after adjusting for important confounders such as younger age and higher prevalence of metabolic risk factors in the South Asian population. The findings from our study, along with recent other studies, would suggest that the overall higher coronary mortality in the South Asian population in the UK is not due to excess case fatality following manifest coronary disease such as myocardial infarction, but is likely to be due to greater incidence of coronary heart disease in this ethnic population. Therefore, we strongly feel that to reduce the excess coronary mortality in the South Asian population, the focus should be on controlling premature and high incidence of coronary disease in this ethnic population. This should be achieved through prevention, early detection, and management of cardiac risk factors in this population. Equally, the emphasis should be on educating the South Asian people about their heightened coronary risk and empowering them to improve their risk modifying behavior.